Welcome to the election conversation today on health. I've been frantically scurrying around the studio getting all things together for a topic that, of course, affects all of our lives, some directly, some indirectly in terms of health conditions right now, and many aspects of this as well, which is why we have assembled this wide range of experts and people involved in the health system. Starting first with Mike King, of course, mental health advocate and the founder of I Am Hope and Gumboot Friday. So, Mike, welcome to the program. Thank you for coming in, and I hope we can have a great convo about this today. Your work right now, of course, it's Mental Health Awareness Week as well. You had a busy week?
Yeah, very, very. We run the largest face-to-face counselling service in the country, and it's out of control. There are so many young people that need help. Always busy.
Yeah.
Way too busy for someone in our business.
Yeah, and of course there's overlaps with mental health and I guess broader physical health as well, which we are going to get into as we go through.
Oh, they're all connected.
Yeah.
Everything is connected.
Yeah. Joining us through the wonders of modern technology as well. Very pleased to have Dr. Rachel Hart from the Cancer Society joining us as well. Hello, Rachel.
Hi, Andrew. Great to be here.
And Rachel, tell us as well with your work right now, what are some of the main focuses that you're directing your resources towards?
Yeah, look, I think obviously cancer is a really big issue within the health system. It's one of the because of the scale of the issue, the number of people who get it, and the interconnectedness with other parts of the health system. We're really interested in those system level changes that we can make to make things better. But yeah, really excited that there are things that we can do to make the system better right now. So I hope that we'll get a chance to talk about some of those today.
That is the hope. That is the dream. And lastly as well, we have Dr. Isabel Hunsinger who joins us today. And Isabel, your journey as well towards joining us this morning is quite an interesting one. Can you maybe catch us up on that quickly?
Sure. I came from Hawke's Bay and it was windy yesterday. And so we had to delay flights, and we finally got in at 4, and we're finally here.
You are. And now you're an advocate of functional medicine as well. So can you tell me a little bit of your background story as well in terms of how you've come to this place of promoting functional medicine, and maybe telling us a little bit about what specifically that is?
Sure. I'm trained as a medical doctor in America, in Colorado, and moved here in 2000 where I got exposed to functional medicine. And functional medicine is another brand of medicine where we learn how to deal with the root causes of an issue. Whereas in medicine, we're trained to take care of more downstream issues like chronic disease, heart attacks, strokes, diabetes, obesity. Functional medicine works upstream to prevent that from happening. So I do both. And I'm more focused on upstream medicine to prevent all this stuff and help reverse disease and give people hope in the process. Because a lot of people think, I don't have diabetes yet, or I don't have cancer yet, or I haven't had a heart attack yet. Well, you know what? That's all a lie. You don't have to have that.
That's a great message to get out there to people. And I think we're going to unpack some more of that as we go throughout the morning too. But look, one of the things that I think has come up in many circles, and I'll give each of you a chance to answer this directly from your own perspective, maybe starting with you, Rachel. But the term crisis in the healthcare system has been thrown around a bit over the last few years. In some cases, denials, others, people trying to say, hey, look, this is a bigger issue than you're prepared to acknowledge. Rachel, in your opinion, is there a crisis in the mental health system in New Zealand?
In the cancer system in New Zealand?
Yeah.
Yeah, absolutely. Look, it's hard to go a day without hearing news of a story of, of wait times, people having to wait months to get an appointment, even after they're diagnosed, just to see a specialist. We hear workforce issues. So down here in Dunedin, where I'm based, we have the radiation oncology service is on its last legs, and patients are having to travel huge distances. We're hearing about cancer patients unable to access medicines or having to pay huge amounts of money or move to Australia, which is obviously not sustainable. We definitely need to change things.
All right. And Mike, do we have a crisis in the health system in New Zealand?
We've always had a crisis problem in health in New Zealand. But if you keep doing the same thing, you're going to keep getting the same result. So our our whole health system is built on crisis. So, in other words, only 2% of people that are in crisis will get the help that they need. So, 98 people are being chucked out the door. So, I'm with Isabel. Everything needs to be dealt with upstream, a prevention model to stop people, getting caught in the funnel. And so, yeah, we there's always been a crisis. There will always be a crisis. But if we keep going the same way we're going to keep getting the same result.
And Isabel, for you, a crisis in the health system, yes or no?
Amen. Yes and amen.
Yeah.
I've been here for 23 years and it's just getting worse. We don't have a healthcare system. We've got a disease management.
Right.
Where we're just taught, here's a pill or here's a surgery for this problem. We're not teaching people, hey, this doesn't have to happen.
And if you fund crisis, all you're going to get is crisis. You get more crisis. So, it's a self-fulfilling prophecy.
And it's interesting to hear from all three of you, I know, in your different areas of speciality. This idea of focusing on prevention is a key part of the work that you're looking to do. I'm curious to know, from what you've heard, at the risk of really diving in with a thorny question to start with, from all the different political parties that are kind of campaigning on the health topic right now, have you heard anything substantial that you think would address this prevention aspect of healthcare? Starting again with you, Rachel.
We haven't heard any major announcements on the big kind of lifestyle factors and regulation areas that we would expect in prevention. So for us, when we're talking specifically about cancer, there's smoking, there's alcohol, there's nutrition, and protection from UV radiation. I guess the only prevention piece of work that we've heard is around increasing the cervical screening and making increasing that out. Just that is a way of preventing cancer because you find cells early. But that's a very small drop in the ocean.
Yeah. Okay. Isabel, from a prevention point of view, what have you heard? Anything? Nothing?
Nothing. Mike, have you heard anything?
Nope.
I haven't either.
Not a word.
Nobody's talking prevention. They're just talking about giving money to the same problems. And it's like, come on, it's time to wakey.
So lots of politicians are promising lots of things, but sadly, politicians don't make decisions on where funds go. So politicians can allocate funding, but it goes to the same organizations that are failing. Like, for example, in cancer, there are lots of things that Pharmac could be funding to save hundreds and thousands of lives. They're never going to do it. Same in mental health. They're never going to do it. They've got these systems in place. They've got these short-term visions in place, and they will fund those short-term issues. They're not looking at the problem long-term. And the reason they don't look at long-term issues is because no politician or bureaucrat gets accolades for something that's going to take 10 or 12 or 15 years to put in place.
Rachel, I see you nodding furiously.
Yeah, I think that's a really great point, Mike, about the nature of prevention, that it's long term. You're preventing, if you get kids to wear a sun hat in a playground, then you're preventing cancer that's 20 years away, 20, 30, 40 years away. So if there's nothing immediate. And also it's really hard for politicians to say, hey, we did this, because it's easy to say we responded to a crisis and look how great we were, but it's hard to prove that you've avoided a crisis in the first place. So I think it's a really interesting point you're making, Mike, about prevention there.
It's like the slash issue in the Esk Valley flooding down there. The real problem was the slash. It's a long-term problem. That's what blocked all the bridges. That's what caused the dam to break. And the government came in and go, look how we dealt with that. But if you're down there like Isabel is, what they've done with all of the silt that came down the river, they've taken it back up to the place where it came from. So on the next rain, it's coming back. But the minister is getting a short-term gain. Quite often I've gone to ministers with long-term plans to get around our appalling suicide rates, particularly with young people, but they're 10-year plans. And the bureaucrats sit there and they say, but the minister needs wins now, Mike. The minister needs wins now. What are you going to give up? There is no win now. There is no win now. But in 10, 15, 20 years' time, when the politician passes, there'll be hundreds of thousands of people there whose lives have been saved because he was brave enough not to take the accolades now, but put in place something long-term for all New Zealanders.
And Isabel, I can see you strongly agreeing. Yeah.
Who is going to be the visionary and not take the accolade now?
Yeah.
You know, you
And-
got to be a parent about it.
And I know this the topic of suicide as well is something that you also very closely relate to. Can you tell us why that's something that means a lot to you as well?
Yes, because I am a suicide survivor here in New Zealand. In 2013, I left private practice because I didn't feel like I was reaching enough people. So I decided to go on social media and start doing online courses and teach people in the homes. Because it's crazy for us to think that healthcare begins in a doctor's office. It doesn't. It begins in the schools, the churches, the homes, and the workplace. So, but then a year later, you know, I didn't learn how to be a social media person, you know, in medical school. A year later, I'm 54 and I'm getting anxious because business isn't working fast enough. And so I became anxious. I didn't sleep when I get anxious, and I only slept about 3 hours for 17 straight nights. And by the end of that, I tried to take my life twice in 3 days. And by the grace of God, that plan was stopped. My husband took me to the doctor. The doctor said, you're going to be on this antidepressant and this sleeping pill for the rest of your life. And look, at that point, I totally surrendered. I was going to do whatever I had to do to get better. And then I took the medicine. And my husband and I went on this journey together for 6 years. And what we learned is that we don't have a mental illness issue. I know that sounds crazy. Your brain is probably tilt. We don't have a mental illness issue. We've got a brain health issue.
Right.
Upstream. When we learn how to take care of all the contributors that are affecting our brain, like nutrition, sleep, adverse childhood experiences, a lot of things. Then we learn how to support that, get that repaired, and then we've got a calmer mind. We're able to be more resilient, durable to disease, you know, resistant to disease, and we're able to deal with all of what life happens. So that's what's happened to me as a medical doctor in the medical system. Now I'm safely off the medication, okay?
Yeah.
But I had to do all that work.
Well, it's speaking again to this idea of, again, the prevention being such a key part of this journey. And, you know, even when it comes to kind of pitching these ideas, Rachel, I'd love to know, again, with your work, no doubt you have many politicians' ears that you're trying to turn your way. Have you found anything that kind of helps you break through and say, guys, this is something you can do right now? Or what is the challenge in your world to try and get some meaningful change out of the people who, I guess, know who you are, love what you do, want to get the approval of the Cancer Society, but also maybe have some perverse incentives in play?
Particularly around election time.
Mike, I think you're right. It is particularly hard around elections. But I think one example of that would be the amazing reforms that we've seen in smoke-free regulation over the last couple of years. I think that this government has really taken smoking and tobacco use as a really key health issue here, and it's been really visionary. It's really world leading legislation. So I think there are moments of opportunity, but as we've been talking about, you really do need people who are willing to grab hold of that with both hands.
Can I just play devil's advocate there?
Oh, please do.
So just because something is a good thing doesn't mean it should be done.
Right.
You'll notice the statistics around gun crime in New Zealand have gone through the roof. So in our effort to get rid of smoking with the draconian prohibition movement, they have created an epidemic of crime. They're doing the same with vaping now. Vaping was coming in ram raids. They're not going into health food shops and taking health supplements. They're not going to veggie shops and stealing broccoli.
Quinoa are on the rise.
No, we have created an epidemic for 501s to wreak havoc in this country. And, I've got 6 kids. I would rather my kids died from cancer than gunshot. And that's what's going to happen. So, again, it's a short-term strategy. Again, it should be education in schools. And I'm not talking high schools either. I'm talking right from early childhood through primary schools. Those are the years that we need to educate our kids around the ills. And it's a long-term strategy. But unfortunately, the outcome of this legislation and prohibition is going to be 50 times worse for the country as a whole. New Zealand has already become an unsafe place, but will be downtown Los Angeles in no time at all. Every day that there is a shooting or a death in this country, and it's so frequent. These gun crime is so frequent, it doesn't even make the front page anymore.
Yeah. Well, look, let's unpack then what real change may or may not be possible. I know there's differing views on what we may be able to achieve already in the studios right now. So when we come back, we're going to talk about that, but also to give you an opportunity listening this morning. If you have a question for our panel about the health system, or maybe you want to make us aware of a challenge that you have encountered, text us through 8168 with the first word Rhema. But we'll be back in a couple of moments to continue this discussion on health for election 2023. And you're welcome to contribute to this conversation today as well. Text through 8168 with the first word Rhema. If there's an aspect of our health system that you'd like us to discuss. But just before we took a quick break, Mike, you shared some thoughts over the incentives that are in play right now, and cancer and crime and how these things can overlap. And Rachel, we thought we'd better give you right of reply.
Thanks, Andrew, and thanks, Mike, for raising those points. I guess I do question where you get some of those statistics. I think to say that the levels of gun crime are raising because of smoke-free regulations is probably a long straw to draw. I think when we're talking about upstream causes, then gun crime is far more complicated than that. You raised the point about education. I think it's a good point, but it's also a little bit of a moot point in terms of, I don't think there's anyone in New Zealand who thinks that smoking is a good idea or is healthy. The education part has worked. And so what we would say is that there does need to be regulation change in order to bring around behavior change. Of course, there has already been a huge amount of behavior change. So this is just bringing those last people into it and meeting our smoke-free 2025 goals.
Isabel, did you have any thoughts on that then, in terms of when we're talking about smoking and the policies that might have been enacted, and maybe there's some unexpected consequences whenever we pass a law or try and direct human behavior in a certain direction?
Well, the bottom line is smoking's not good for us.
Right.
And so people have been led to believe that vaping's okay too.
Right.
It's not. I see people and I go, "Are you a smoker?" "No, I vape." I go, "You're still getting those chemicals. They're still getting you addicted. They still have you." So either one are not good.
So look, let's expand then when we're talking about the health system in general. I mean, I think one thing that comes out to me, and I think Mike will probably go to you directly on this one first up, but we talk about allocation of resources. And on the one hand, last I checked, that health is the second most allocated aspect of the budget each year. They put billions and billions and billions of dollars into this. And yet we also we live in a parallel universe where we don't have enough resources, we don't have enough people. We are, on the one hand, have more than almost anything else, and yet not enough. What's going on?
Okay, first off, there is more than enough money allocated to health to solve the problem. There's, particularly mental health, there's more than enough money there. But unfortunately, maybe 40% of it is going to administration. It is all designed to keep organizations safe. So it's got nothing to do with people. I mean, if you just as a random example, because everyone can see it every day, the cone market, the orange cone market, it costs $350,000 to build a speed hump. You know, 350,000. That's not a pedestrian crossing hump. That's probably double.
Yeah.
But it costs half the price of a house to put one speed bump in. And it's not the materials that is costing anything. It is the cones. It is the trucks with the X's on there. It is the 9 people standing around on their phones watching the cones, watching the 2 people working.
Sure.
Now, the argument that WorkSafe and all of these organizations would give you, it's about keeping the workers safe. They don't care about the worker. They have no desire to protect the worker. It is to protect them. Now, there are two things in this country. There are politicians and there are bureaucrats. I've never met a politician I haven't liked. Every single one here, if you sit down with a politician, they're good people.
Yep.
And they go into Parliament to make a change. Their desire is to help people. Once they're in there, it all changes. But once they've been in one, their first instinct is to help people. Bureaucrats. I've never met a bureaucrat I've liked. Bureaucrats don't go in there to help people. They go in to climb the ladder. And in order to stay safe in that system, you have to protect yourself, which is the rise of risk management. So they're putting all of these. If there was an accident on that speed hump and someone died, that bureaucrat will never advance. He will never work again. So we're putting in hundreds of thousands of dollars to keep bureaucracy safe. And I'll give you a classic example of that. 10 years ago, I came up with a program in schools to help young people. So 10 years ago, young people weren't going to see counselors, but they would once a friend recommended them. So my program was really simple. Bring in kids in their first year out of high school to work as a bridge between the pastoral care teams and the kids and get them talking about little problems before they become big problems, before they become suicidal thoughts. Very, very, very simple program. The kids weren't taking on the problems anymore, because in those days, kids would share their problems with everyone in the school and would create this tidal wave of fear. So it was a really, really simple program. So I went to Ministry of Health. I worked with them for 6 years. 6 years to come up, and they just kept putting layers and layers and layers of compliance. And then at one point they said to me, you mentioned suicide. We can't talk about suicide in schools. You can't have kids talking. And I went, you've heard of lunchtime? Because that's what kids do at lunchtime. So this program was really simple. And then they said to me, this has to be rock solid before we put it into schools. Because if one child dies, then it all comes back on us. And I said, kids are already dying in schools. And their response was, yes, but we're not in those schools.
Right.
Once we're in those schools, so we have to be rock solid before we go in. So all these hooies and no doies would have cost central government at least $2 million. And with one member of the Ministry of Health team was out, we'd go back to square one. So you could be at square 5, but as soon as one goes, you're back at square 1. And this is where all of our money is going. It's ridiculous.
Right. Well, Rachel, I mean, you're obviously having to interact with the health system fairly frequently as well. Does your experience mirror Mike's? Do you have a different take on the incentives that are in play and even the level that bureaucracy is affecting cancer care in New Zealand?
Yeah, I mean, I certainly think that bureaucracy is an issue at the moment. Our bigger issue is that we don't know where the bureaucracy is with all of the reforms around Whatuora and all the movements. There's just a lot of people moving, and we don't seem to know who to talk to and who's working on what.
They're the same people. They're exactly the same people. They've just got different titles, blaming their old selves.
So I certainly think that's the trick in terms of how we can make those improvements. Though I think that having more data, and having more centralized data is really key to that. That in cancer, for example, a few years ago we couldn't even compare the treatments that someone for a particular breast cancer was getting in Auckland versus what they were getting in Dunedin or what they were getting in Christchurch or Wellington. And so we had no way of actually learning from it, measuring who which of those treatment regimens are most effective, which are working with particular genetic streams that might be quite unique to New Zealand. So I certainly think that collating that type of information is a really significant part of the system learning and learning how to attribute resources more accurately and more effectively.
Well, I mean, that idea of information sharing, I think anyone who's been through a hospital in the last little while will find the difficulties of, getting the different info from the different specialists and doctors and things that you may have spoken to. But Isabel, in your experience, do you feel like that is something that could be an easy win? He says in inverted commas, easy enough win for a change of government to action? Or is there something else that you think is kind of getting in the way of the care that we really should be delivering people?
I believe that we need to start working in the families more, in the homes, the schools, the churches, and the businesses.
Stop it with your common sense.
And very simple things. I've got ideas, like for instance, in the family, in the Bible, it says in Deuteronomy 32:30, where one can lead 1,000 to flight, one mother with her family who buys the food, two can lead 10,000 to flight. Can you imagine if the mother and the father know how to buy food instead of opening up a sachet or going to the fast food stores and learning how to eat together? Studies have shown that a child who eats with their family one meal a day decreases their risk of mental illness, bulimia, anorexia, obesity. We got to start bringing the families back together. So I've kind of given up working in the healthcare system. I'm not doing that. I'm working directly with the families, with the businesses, the homes, the schools, the churches, because I've done the medical system for 30 years, and it's just, like Michael says, too much bureaucracy, and I can't be bothered. It's too much. This will change, but my focus is more with the people.
And of course, for that to work, we need to have the people who are available to work with the people. And that's something else that's been raised a number of times too, in terms of our lack of mental health care workers, but just broader healthcare workers in New Zealand as well. And I'm curious to know for you, Mike, as well, when you set up your programs, that on the one hand, we're told again and again, I think, what was it, about $2 billion was allocated in a prior budget for mental health services.
$1.9 billion.
Yeah.
Wow.
And then later we found that barely any had been spent because
It's been spent. They just don't know where it's gone.
Right. Well,
because they don't collect data.
So
They do not collect data, and it's completely incompetent. I'll give you just one example. The service that is closest to ours is the counselling in schools. So the Ministry of Education put up $44 million for 400,000 counselling sessions, or not counselling, 400,000 sessions over 4 years. That's 100,000 sessions a year at $110 a session. In the year one, they completed 9,600 sessions, so 90% down on where they were supposed to be, at a cost of $6.4 million, which works out to $485 a session. Now, the reason they could only do 9,600 sessions was because their pay rates are too low. So they pay their specialists between $30 and $60 an hour. In that, over that same time, so 2 years ago, we were funding 550 sessions a month at $78,000. Now we do 3,400 sessions a month at a cost of $520,000 a month. That's what I have to go and find. We're not funded. So how their system works is like a taxi service. So they'll get 5 NGOs that they already fund down to Wellington. They'll have a big hui, and then they'll allocate to 3 of them. Got to have 3, just in case one of them screws up, we can point to the other 2. So they have 3. Now, they run them like taxi companies. Now, that organization comes back, they buy a big building to put the people in. Then they have people outside the buildings, lawyers, accountants to fill all the books. Then they've got to go out and buy the taxi stands. Then they go and buy the cars. And then they put the drivers in the cars. The drivers are the counselors, right? Then they pay the counselor $60, between $30 and $60 per session, per cab ride. And if you're a punter and you want to use that service, you have to go to the taxi stand and you have to choose the first cab off the rank. You can't choose the driver you want. You have to use, and those sessions cost $485. Now, can you imagine what would happen if the New Zealand public found out I was charging them $485 for a Gumboot Friday session, but only paying the the counsellor between $30 and $60? There'd be knocks on my door. Mr. King, where is the money gone? Where is the money gone? People are dying. I'm sorry, Simon. Mr. King's just left in his Tesla. We'll try and get him back tomorrow. We pay $147 a session for the counsellors, and the only thing we get back from Te Whatu Order is you're overpaying counsellors. There is more than enough counsellors in this country to work prevention. Now, the big problem that I have is I'm constantly accused by politicians and bureaucrats who say, Mike, you are giving free counselling away to kids that don't need it. And my response to them is, you're looking at counselling as a crisis solution. But once a child's in crisis, it is too late to talk to somebody. You need medicalisation. Our kids don't want counselling when they're mentally ill. They go and talk to someone to stay well. You know, we've got to work on a prevention model.
Well, let's talk then about, again, the cancer model in particular too, because when we've been talking about care and the levels of care, I know that in part of the, you've got like a 4-point plan that's available on the Cancer Society website as well, Rachel, that talks about how, you know, you're looking to deliver this. One of the factors of that is care close to home or accessibility, which again, I think, you know, overlaps with some of the things that Mike and Isabel have spoken about as well. But what limits that accessibility? Is it, again, that issue of, you know, do we not have enough, you know, specialists or clinics or whatever that are close to people? Has the money been spent on something else? Like, what's your perspective on how we can achieve that? It's a great goal. I think a lot of us would support that. Everyone would support that. What gets in the way?
Yeah, look, I think it's a great question, Andrew. I think some of the things that get in the way are the workforce shortages. If you need to see a specialist and there's not a specialist in the town that you work in, then suddenly you're flying across the country to see people. If the treatment team is short-staffed, then you're flying away to get treatment, and that could be you're away from home for 7 weeks, which is a huge time when you're not working, maybe when your partner isn't able to work in the same way because they've got to take care of the kids or the family, and you're accruing huge amounts of costs. So some of it is about workforce shortages and where our specializations are. Some of it, though, is also just about a lack of services. So one of the points that we raise is around lymphedema services, that not every part of the country has it, yet it's a really common side effect of cancer treatment. You have some of your lymph nodes taken out and the effect is then swelling. And it's a really simple, it's not a simple service, but it is a service that should be available everywhere so that people can access it. So those are some of the barriers, but there are also enablers that we're not letting in at the moment. And so as cancer medicines are evolving, and Isabel, I appreciate this is the downstream. This is once people have cancer, but the cancer treatments are evolving to be more easily taken in pills, which then can be given in local treatment centres in over time, perhaps in GPs or pharmacists. At the moment, because we're so far behind in funding treatments, we're not getting some of those things that would enable us to give treatment closer to home. So those are some of the aspects that we talk about in our manifesto.
It's such a wild paradox, isn't it? Again, where we're hearing on the one hand shortages of funding and lack of supply in the one area, when at the same time we know there is so much money being spent. But look, we're coming into our final segment of our conversation on health today. I feel like we could go for another 2 hours at this rate. But nevertheless, remember, if you've got a question for us today, you can text it through 8168 with the first word Rhema. But when we do come back, I do want to hear, before we go, is there such thing as a positive vision for the health services that we represent here in this panel today? What is one thing you'd love to hear that would be an easy win for any political party to pick up and run with, and maybe that should dictate who you vote for in this coming election? That's what we're going to ask when we come back after this quick break. And we've had a great conversation already this morning on health and how we can approach the challenges that exist within the system, where those challenges really are. And so with all that said, in our last few moments, I would love to give each of my panelists an opportunity to share something that maybe we can be prioritizing within our health system, maybe if there is an area that can help direct where we send our vote. And Rachel, we'll start with you. What would be maybe an easy win, a positive vision for the future that New Zealanders could really expect to see within their health system?
Yeah, well, thanks, Andrew. Just to pick up on some of the points that we've said already, I think firstly, investing in prevention and also in early detection will save lives and will save the system money. You know, stopping people from getting cancer, finding it early is a huge way that we could be making a change. But in terms of just the one idea that we could change and make a difference for cancer patients, I want to talk about transport. And that seems like an interesting point for someone from the Cancer Society to be talking about. But with so many people traveling across the country for treatment, as I've talked about, and spending so much time away from home, one of the things that is a real barrier is the cost of that to New Zealand families at a time when they already are facing huge cost burdens of being out of work and of having cancer treatment. The government's National Travel Assistance Scheme just is falling short in every way. The rates that are being paid are too low. So the mileage rate is 28 cents a kilometre.
Oh, wow.
Which is nothing. If you're traveling from Tiana to Christchurch, it's not covering your costs. The nightly rate that they pay for accommodation is $100 a night, and where can you get accommodation? And if you think
nowhere I'm going to stay, that's for sure. Jeez.
So if you think that you might be away for 7 weeks away from home, that's kind of upwards of, that's $7,000 or $8,000 that you might be accruing just in accommodation. And so we're calling on the government to to make those levels better and to improve the access criteria. And also the final thing that we'd really like to see is that people, at the moment, you can only access that after you've finished your treatment. So you have to incur all the cost and then claim it back.
Oh, wow.
So actually to get it up front as well. And that's a really simple change that would make getting to cancer treatment far less stressful and actually mean that people are able to do it.
Oh, dangerously practical this morning. Isabel, what stands out to you? What could be a win or a positive vision for the future that people could look out for in terms of directing their vote for 2023?
So many. Bottom line is vitamin D. Vitamin D is so important in the prevention of anxiety and depression. But a lot of medical doctors don't even know how to test. They think that the test that we get the results of, if it's within normal limits, that's normal, but it's not. It's not optimal. So checking vitamin D levels and teaching the doctors that an optimal vitamin D level is between 115 to 200 nanomoles per mil here in New Zealand.
Yeah, and that would have flow-on health effects for everybody? Like, what would be the effect of something like that?
Well, brain health, prevention of breast cancers. It's been shown, the research, it helps prevention of cancer. It helps with skin care. There's a multitude of benefits of vitamin D.
And Mike, for you?
Really simple, and I'm only talking mental health here. It's free. So we focus, at I Am Hope, we focus on positive societal attitudinal change. The way we look at mental health has to change. So over the last 13 years, we've spoken to over 350,000 kids. 40% of kids in school, this is what we've learned, 40% of kids in school will have a major crisis associated with some type of suicidal thinking before they leave school. The problem that we have is 80% of those kids never reach out and ask for help. And the reason they never reach out and ask for help is because they're worried about what society will think, what society will do, and what society will say. Yet our message to kids with suicidal thoughts is, hey, reach out and ask for help. It's like, I've just told you I'm scared of sharks, and your solution is, hey, go swim with some sharks and a dolphin might come along. So we need to change that thinking around to what are we all doing to make it easier for our kids in crisis to reach out and ask for help. We are not leading by example. We're telling kids what to do. We need to show them what to do. So as parents, we need to show more vulnerability. We need to talk to our children when we're under stress, because if you don't talk to your kids when you're under stress, they know you're under stress. And if you're not telling them why you're under stress, they'll make it about them. So we need to be more open. We need to show our kids that we all, life is full of ups and downs. And even me, the rock solid, dad, I have my ups and downs too. We've got people in schools at the moment teaching kids about mental health. Kids don't need to learn about mental health. They need to know that they are normal. They need to know that the things that they are going through right now, everyone experiences. The number one rule in mental health, no one has got their together. We are all just trying our best.
Yeah,
Amen.
absolutely. It kind of reminds me of back when I used to work in adult education. You go into businesses and you talk about how you build trust with people. And they say things like, well, I've got this policy, my door is always open. And I'm like, how many people ever walk through that door? They say, well, nobody, but my door is open. I say, well, that's nice. But in terms of, how you facilitate that, I do want to double down on that point about the vulnerability of sharing your own struggles, right? That at least, you build trust by giving trust. And if I share my story of weakness with you.
But the problem is, as adults, our timing's always really bad. So when our kids come to us, your girlfriend's just dumped your son. Don't worry, same thing happened to me, but I managed to hook your mum, didn't I, mate? So what we think we're saying is, this is a universally shared experience. What our kids are hearing is, as soon as I talk about me, you make it about you, or even worse. So even when you screwed up and bad things happen, you overcame them, because, that's who you are. So our timing of our vulnerability needs to be on point. And the best time to do that is dinners at the table with the family.
Yes. And on top of that, Mike, sorry. Michael's only when he's in trouble.
Yeah, that's my mum.
Or your mom.
Michael?
Being here for 23 years, this culture of toughen up and she'll be right, mate, is so wrong. And people are, I don't know if you've ever heard of Dr. Gabor Mate.
Yes, I have.
The wisdom of trauma. So much trauma in this country. No wonder we've got so much suicide, and nobody's talking about it. And we've got to learn to have crucial conversations. I had to learn as a mother who tried to take her life.
We bury that.
Yeah.
Learn how to have those conversations with my daughters and say, hey, I'm sorry, but that's where I was.
Here's the big trauma elephant, just real quick before you go to Rachel for the last word.
Yeah.
1 in 4 girls in this country is sexually abused. 1 in 8 boys is sexually abused in this country.
Who's talking about it?
And you never, ever, ever hear it. It's the big elephant in the room. So all mental health problems are based in trauma.
Well, and I was going to say, just kind of connect those thoughts together, Rachel, with your work as well. And in terms of prevention, I know that, there are studies that link, people's mental health and those things to their physical health as well. And are those areas that the Cancer Society has also been building awareness of, or what's your understanding there?
Yeah, I think certainly the links between mental health and behaviors that support health are really clearly documented. So if people are low in resilience, then they're likely to be drinking more alcohol and likely to be eating less good food. So there are some really direct links with healthy activity.
Yeah. Yeah, and then in terms of like cancers and things like that in later life too, right? It's all downstream of a lot of these things.
Yeah, absolutely.
Look, I feel like there's so much more that we could have talked about as well, guys, but would you believe it's almost 10 o'clock already? So I want to say a massive thank you to my guests today, Mike King, Dr. Isabel Hunsinger, and also Dr. Rachel Hart. Thank you guys so much. And thank you to everybody as well for listening today. We're going to put this conversation up on the website a bit later on too. So if you want to spark up a convo with some of your mates, by all means, have a listen and see if it's going to change where you send your votes later on. Mike, you got a cheeky look on your face. You're thinking.
Just the moron between two doctors. It's great.
I think you acquitted yourself pretty well. Don't worry.
Thank you.
That is it. Look at us affirming one another. You know, we're putting things into practice. Look, this has been our discussion on health for election 2023. Many more to come as well. But remember too, all of these discussions will end up on the Rhema website and different social channels for you too. So let's try and have as informed a decision as we can around where we vote. If health is something that is a priority for you, I mean, let's be honest, if you're alive, you've got a health issue, then this is something to be mindful of. So head along to rhema.co.nz and keep yourself up to speed with everything else we're going to be bringing your way in preparation for election 2023.
For more Election 2023 content, visit shinetv.co.nz and alltogether.co.nz.